Hello and welcome to the My Mind Year 1 Module 2 training for behavioral health. My name is Sarah Moore and my pronouns are she, hers, and I'm excited to meet with you over the next couple hours to present organizational support for suicidal risk and patient self-management. We appreciate all that you do daily to prevent suicide at the practices that you work at. And we always want to support you in that. So today, we will start by covering the My Mind recommendations for suicide risk screening and assessment and highlight the importance of providing lethal means counseling. You can take a break at the hour mark or feel free to pause this video at any time if you'd like to take a break. This is a 2-hour training. So for the second half, we will cover the importance of involving loved ones in a patient's care who is at risk for suicide, as well as cover other patient self-management strategies, including providing community resources for support, collaborative safety planning, and providing caring cards or follow-ups after an appointment. Last, we will introduce the suicide prevention care pathway and discuss strengthening care pathways and how coordinating between primary care and behavioral health providers can decrease suicide risk for our mutual patients. I'll wrap up today's meeting by providing some references and key takeaways. And as always, make sure you're taking care of yourself physically and emotionally. And please reach out to us and let us know of any ways that we can support you going forward. Thank you for being here today. Just a reminder here, support for My Mind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships Program. Although Blue Cross and My Mind work collaboratively, the opinions, beliefs, and viewpoints expressed in this training do not necessarily reflect the opinions, beliefs, viewpoints of Blue Cross or any of its employees. I'll start by discussing how screening patients for suicide risk in primary care can help to identify patients in need of further assessment and intervention. At My Mind, we promote asking every patient about suicide risk at every encounter. Some patients may openly discuss suicidal thoughts. Others directly indicate risk of suicide or self-harm, while some may live in silence with the pain of feeling that it would be better um, without them or easier if they were not here. Dr. Frank, one of the co-directors of My Mind, would say that we must keep in mind the people who are silently at risk or who do not know that they are at risk. These are the individuals that need every opportunity possible to get the help that they need. We recognize that this can feel like another ask for busy providers who are already addressing so many things in a short amount of time. So we are hoping that the entire clinic can come together to support screening efforts when possible. Most of you are already aware of or using questionnaires that make screening for suicide risk easier. So today we are going to discuss how you can automate the screening process to be as streamlined as possible using the PHQ-9 or Patient Health Questionnaire 9, as well as discuss some other possible questions to use with patients that can support identifying suicide risk. Henry Ford Zero Suicide Guidelines recommend using the PHQ-9 at every clinical visit. The ninth question of the PHQ-9 specifically screens for thoughts that the patient would be better off dead or of hurting themselves within the past 2 weeks. Although the screener may not need to be done at weekly intervals for patients coming in more frequently, repetition can be helpful for patients to get used to the process of completing the questionnaire and ensure that patients aren't being missed. It is critical for both primary care and behavioral health providers to screen for suicide risk, as we know that if we do not screen in primary care, many patients may fall through the cracks. So when administering the PHQ-9, it is important that providers review the score at the beginning of the appointment. The sooner the provider knows the answers, the sooner they can plan for what next steps to use or which care pathway is best. While we recommend screening patients with the full PHQ-9, we do understand that this may be a difficult task to start. For that reason, it is also acceptable to start with the PHQ-2, plus item or question number 9 of the screening of the PHQ-9 to screen for suicide. Now, I did highlight the questions that we suggest using here if unable to use the full PHQ-9. Again, those are questions 1, 2, and 9. And we will mention PHQ-2 plus item 9 throughout the training today, and that's just what we're referring to. Now, there are some other questions on the PHQ-9 screener that also relate to suicide risk, such as questions about sleep or feeling bad about yourself. For this reason, we promote completing the full PHQ-9 questionnaire with patients. At My Mind, we think of the PHQ-9 as our behavioral health vital sign. We understand if your clinic is used to doing the PHQ-2 and feeling unprepared to start administering the full 9. Therefore, our suggestion is starting at minimum with that PHQ-2 plus item 9. It's important to recognize the difference between screening for depression and screening for suicidality. In the upcoming slides, we will discuss further the importance of screening for suicide risk among all patients. So when considering the PHQ-9, there can be some hesitancy due to worrying that this can potentially make more work for providers, as well as concern about not having the staffing to address scores in a timely manner, especially if this is being done via the electronic medical record or EMR. So to calm some of those fears, I do want to mention here that per the research, only about 2.9% of primary care patients scored a 2 or 3 on question number 9 of the PHQ-9. And research states that there is more of a longitudinal risk than a same-day risk. Obviously, looking at the statistics here, the research does state that there is an increased risk for those with a positive screen, but it does not necessarily mean that we need to ring the alarm the second that that score comes in. The hope is that screening processes will be streamlined and EMRs can be used or leveraged to put protocols in place to help providers address suicide risk. There are some safeguards that clinics can put into place when using the EMR for screening, such as sending out the questionnaire 48 hours prior to the patient's appointment, and putting some wording in the screener recommending that the patient go directly to the ER if they are in danger of killing themselves. We suggest that clinical staff contact the patient the same day if they are a new patient to the clinic and the patient scores a 2 or 3 on question number 9. And if they are an established patient, the recommendation is for clinical staff to follow up within 48 hours or using best clinical judgment. It may be helpful to check in with the legal team at your PO to ensure that they approve of the wording and disclaimer of the protocols. Some of you may already be familiar with the Framingham Heart Study and Risk Model and possibly the research that was behind this. So to make it short and sweet, this study is related to research on screening for risk factors and stratifying risk for CV or cardiovascular disease. This was an iconic, multi-generational and longitudinal study that found that the Framingham score can be used to help physicians quantify risk and guide preventative care related to cardiovascular diseases. The study found 20 to 30% likelihood of coronary heart disease for a patient with the highest risk factor or in the highest risk bucket. This research really changed the way that healthcare providers screen for CV risk and the care that they provide to patients at higher risk for CV issues. It is why in routine physicals, doctors check for high blood pressure, high cholesterol, unhealthy eating patterns, smoking, those different things, right? So at My Mind, we have adopted a similar understanding of the suicide risk model using the PHQ-9 for screening for suicide prevention. Research demonstrates that the likelihood of a person having a suicide attempt or dying by suicide during the 2-year period after a positive score on the PHQ-9 is 50% more likely if they have that positive score on the number 9 question of the PHQ-9. There's a 50% more likely chance that they may attempt or die by suicide during that 2-year period. Again, showing that more longitudinal risk. MyMind is using the PHQ-9 as a gold standard of care. And like the Framingham risk model, the pioneers of zero suicide in MyMind created an assessment and guidance for next steps based on research that has been done on the PHQ-9 and risk factors for suicide. Some of our participants are using other questionnaires in their practices, and we want to recognize some of those here. We do suggest using PHQ-9 or at minimum that PHQ-2 plus item 9 if PHQ-9 is not feasible. You'll also notice here on the slide that we call out the Columbia Suicide Severity Rating Scale, or CSSRS. This is another screening tool that is commonly used to gauge suicide risk. Although you won't be affected by the screening performance measure in the first year, in future years, participants in MyMind are scored on a performance measure related to screening rate, and for that, we consider the PHQ-2 plus item 9 of the PHQ-9. For that PHQ-2 plus item 9, that PHQ-9 using item 9, and for the CSSRS, we will use question number 1 to screen for suicide risk. So using item 9 of the PHQ-9 or that item 1 or question 1 of the CSSRS is what we'll be looking at for that performance measure. Okay, so moving on to the zero suicide risk assessment. Now that we have discussed how primary care and behavioral health can screen and identify those at risk for suicide, in a moment we will discuss the assessment that will be done in behavioral health. While we don't expect primary care providers to complete a comprehensive risk assessment, it is important that primary care is aware of the risk factors for suicide, especially risk factors related to high and acute risk. So we often associate depression and substance use disorder, or SUD, with suicide, but I wanted to take some time to look at the research. This graph originated from a study that included a dataset of over 2,600 individuals from 8 healthcare systems who died by suicide between 2000 and 2013. This is compared to a control group of over 260,000 individuals who did not have a death related to suicide from 2000 to 2013. Among patients in the case group, 51.3% had a recorded psychiatric diagnosis in the year before death. After adjustment for all listed diagnoses or looking at that fully adjusted model, suicide risk remained highest among individuals with diagnoses of bipolar disorder, depressive disorders, and schizophrenia spectrum disorder. Statistics show that only 45% of people that die by suicide were given a mental health diagnosis within the year prior to suicide. And in this study, only 29% of those individuals received specialty behavioral health outpatient care. If you look at this graph, you will see 9 physical health conditions, including back pain, brain injury, cancer, congestive heart failure, COPD, epilepsy, HIV and AIDS, hypertension, and sleep disorders were all associated with suicide. Hypertension and back pain were the most common conditions for individuals who died by suicide in both the control group and when adjusting for age, sex, mental health, and SUD. Previous research on the U.S. veteran population has implicated chronic back pain as a strong risk for suicide. However, further research is needed to investigate whether opioid use for pain management contributes to that risk. TBI had the largest increased odds after adjusting for other variables. And a diagnosis of a sleep disorder also showed increased odds at almost 19%, compared with less than 5% of the control group. Multimorbidity was also considered in this study, and it was found that having 2 or more diagnosed physical conditions was associated with an increased risk for suicide, even after statistical adjustment for age, sex, and psychiatric conditions. Those statistics, along with these last two slides, tell us that if suicide prevention efforts are targeted mostly at behavioral health patients, those efforts will miss the majority of the patient population that is at risk of dying by suicide. Significant change in health status can be a major stressor that we know often precipitates feelings of hopelessness and helplessness for our patients. So before we start talking about the Zero Suicide Risk Assessment, I just wanted to preface this part of the presentation with a slide to clarify what we expect from primary care and behavioral health in relation to suicide risk screening and assessment. So screening is meant to identify if someone is at risk for suicide. The screening, for example, the PHQ-9, can be completed three ways. Verbally, asking the patient questions, having the patient complete the questionnaire themselves on paper, or the patient may be able to complete a suicide risk screening electronically via the EMR before their appointment. Support staff like an MA or case manager or nurse can also help with screening efforts. Assessment further helps to quantify risk and aids in decision-making about next steps. Screening completed in primary care and behavioral health, and both is completed in primary care and behavioral health, and both providers should assess for immediate danger, asking about plan and intent, access to lethal means, and history of or current substance abuse or use. With primary care specifically assessing for any acute or high risk factors. The difference is that behavioral health will be completing the comprehensive zero suicide risk assessment, asking about risk factors and protective factors as they complete their biopsychosocial assessment. At My Mind, we feel that it is important for behavioral health to be aware of what we recommend for their primary care partners and vice versa. I wanted to provide some tips and do some myth busting related to asking the suicide question. First and foremost, asking a person directly about suicide actually has the potential to lower risk. We should be careful not to focus solely on suicidal ideation as the main determinant of risk, and keep in mind other risk factors that cause a patient to be at heightened risk for suicide. It is important to recognize that at times the patient does not even realize that they are at risk until they are out of hope, feeling helpless, or feeling that ending their life is the only way to find relief. Asking questions about extreme anxiety, chronic pain, or substance abuse can help you identify patients in need of further intervention to prevent suicide. Take all signs seriously and use screening tools that help providers identify those at heightened risk. We understand that providers may have some anxiety related to asking the suicide question. Here are some tips and prompts to get you started when having this conversation with your patients. It is important to be clear and direct with your questions, to be compassionate, and to not ask leading questions. All of these tips are important, but another few that I want to highlight here are that if you feel uncomfortable, still ask, allow the person to talk openly and freely, and try to be present in your tone, body language, facial expressions when you're having these conversations. And remember, even if you're still getting comfortable asking about suicide, it's important to push through that discomfort and ask anyway. The more you practice, the more comfortable you will become. And when in doubt, always ask about suicide. Here, I just want to mention the elephant that can be lingering in the room. Sometimes patients come in looking very down or distraught, and even though we care and we want to be supportive, it may feel like asking about suicide is opening a can of worms. I just want you to keep these things in mind in those situations. Your body language is always saying something to the patient, especially if you are uncomfortable asking a patient who presents as like depressed or angry or anxious about suicide. So your body language will kind of tell on you in that situation. And this uncomfortable feeling usually stems from concern for the patient and is important to address within yourself as a clinician. Letting the patient know you care and want to support them can help ease both the provider and patient's discomfort with the question. And sometimes it can be the patient being more avoidant than the provider. So in this case, be persistent, let them know that you care and are open to listening. When asking the suicide question, it is best to ask directly about suicide. I did provide some less direct approaches to help get the conversation started, but we recommend only using the less direct approaches as an opening to having a more direct conversation about suicidal thoughts. For example, saying to the patient, "You seem down today," and having some conversation, asking them how they're doing, and then saying, "I am concerned about your safety. Have you been considering suicide?" Here are some possible follow-up questions. After a patient acknowledges suicidal thoughts, it is imperative that both primary care and behavioral health ask about plan and intent. So these first two questions are non-negotiable. You may find it helpful to ask any or all of the additional questions provided here to have a better understanding of a patient's risk level so that you as the provider can feel more confident with the patient's plan of care. And these questions can also be rolled into the suicide risk assessment you'll see here shortly and can help you identify what supports can be included in patient care. You know your patients best, so depending on the patient and the context, any of the questions after the first two may be helpful additions that support further assessment. It's important to understand the difference between passive and active suicidal ideation, as this may help the provider decide next steps in the treatment for the patient and their plan of care. On the slide here, you can see examples of active suicidal ideation when a patient has specific thoughts about how they would kill themselves, as well as passive suicidal ideation when a patient wishes they were not alive but does not have a plan to harm themselves or kill themselves. Passive suicidal ideation still warrants safety plan resources, should be taken seriously, and documentation of steps that the provider has taken to keep the patient safe. Some individuals do have passive suicidal ideation throughout their lives, so it is important to investigate if this is something new, and if not, what has kept the patient from acting on these thoughts. I want to reiterate here that we know that there can be some anxiety related to asking someone about suicidal thoughts. I would like to help you feel more comfortable and prepared to do so. It does get easier with repetition, so practicing with other staff or attending upcoming My Mind office hours to role play and practice vignettes may help. While we are offering some opportunities for office hours in the new year in 2026, we do want to let you know that if these do not work for your schedule, you can always reach out to myself or the coordinating center to request a time to meet and discuss questions you might have related to the My Mind trainings. While we want practice clinical champions and liaisons to disseminate My Mind information to other providers at the clinic, it can be helpful for support staff, such as front desk staff or MAs, to attend a training such as QPR or Question, Persuade, Refer. This training can help non-clinical staff feel more equipped to manage suicidal crisis that occurs in the clinical setting and be able to support the patient and clinical staff. I included the website here to check out for anyone who is interested, so you'll see that here on the slide, qprinstitute.com. Next, we will go a little more in depth to discuss risk factors and warning signs for suicide, as well as discuss protective factors that help keep the patient safe. We suggest screening every patient at every encounter because it may not be as evident to the provider how a physical illness or behavioral health symptoms are affecting a patient on any given day. For this reason, we also suggest that behavioral health does a comprehensive risk assessment. Ideally, primary care administers the PHQ-9 and puts processes in place to automate and streamline this practice so that every patient is screened at every encounter. If a patient is identified at risk for suicide, primary care screens for immediate danger, plan and intent, and a warm handoff is made to behavioral health. We realize that access to behavioral health can be limited. This is why we discuss in the trainings with primary care that it is important for primary care to know the risk factors that may cause the patient to be at higher risk, as well as what protective factors can be added and considered to help the patient be safer in interim. Risk factors are situations or problems that can increase the possibility that a person will attempt suicide. My mind organizes suicide risk into four categories: acute, high, moderate, and low risk. So, how are we able to stratify risk in this way? On the slide here, you'll see that risk factors are considered for which risk factors are considered acute risk for suicide. Our co-directors, Dr. Frank and Dr. Amadani, and the behavioral health team at Henry Ford Health have worked to make these risk buckets as clear as possible and ensure that risk stratification is evidence-based. It is important to recognize that a patient is considered at acute risk for suicide if they present with a suicidal plan or intent, have a history of suicide attempt in the last 30 days without any intervening mental health treatment, or if the patient has severe hopelessness, current uncontrolled mania, or current psychosis with command hallucinations and or severe paranoid delusions. As Dr. Frank would say, these should be very clear warning signs that a patient needs to be hospitalized. If the patient presenting with any of these symptoms is not hospitalized, there should be very good clinical reasons and considerations for safety in place that justify the decision to not send that person to the ER or hospitalize that patient the same day. On this slide, you will see risk factors that are considered high risk for suicide. We know that individuals using substances are more likely to die via overdose, and we also know that impulsivity and lack of inhibition tend to go together with drinking and using drugs. So it is important to keep in mind substance use history and current use. Global insomnia, when a patient is sleeping very little or not at all, is also a predominant risk factor and has been linked to suicidality. As providers, we should always be looking for symptoms of severe depression, anxiety, anhedonia, or when someone can't enjoy things they usually would, or any recent mental health emergency department visits, acute stressors or losses, or a suicide attempt within the last year. Recent mental health emergency department visits and high scores on the PHQ-9 item 9 of more than one, so a 2 or 3 on item 9, or a score of more than 20 on the full PHQ-9, also lets us know that a patient may be at higher risk for suicide. The moderate risk bucket has the most risk factors. Individuals with a family history of suicide, history of drug use disorder within the last 5 years or opiate abuse in the last year, as well as those with military background or who are LGBTQ+, are among populations that are at heightened risk in comparison with the general population. We also want you to recognize that individuals without any other risk factors may be considered in this moderate risk category due to impulsive behavior, moderate depression or anxiety, current hypomania, an eating disorder, chronic history of chronic pain, or having a traumatic brain injury or inpatient psychiatric hospitalization within the last year. It is important to note that an answer of 1 on question 9 of the PHQ-9 is considered moderate risk as well. I just wanted to add in a reminder here that any patient that has a behavioral health diagnosis has some risk level, even if low. So in the low risk bucket, we include mild anxiety or depression, bipolar disorder or psychotic disorder in remission, multiple chronic medical problems, and any other mental health diagnosis or personality disorder. At some practices, leadership has been able to build the stratified risk assessment into the EMR. However, you might not have the ability to do this at all, or that it might just simply take time and planning. Therefore, we are providing you with a 2-page or front and back checklist with the different risk buckets that you can read through quickly. That will also have a protective factor checklist and other important things to consider when assessing for suicide risk. Since behavioral health will mostly be doing this assessment, it is most important that you all have access to this, but it may be helpful for primary care providers to have on hand to consider possible risk and protective factors for their patients. So you can see a picture of the Henry Ford Zero Suicide Risk Assessment here on this slide and the following slide. Again, this assessment tool can help behavioral health providers to identify risk factors, to stratify risk, and consider existing and additional protective factors that can be added. And here you'll see the second page of the assessment. This includes determining level of care needed for the patient's safety and referral considerations, including psychotherapy, brief interventions, including lethal means removal, and medical management. And you can find, again, this 2-page risk assessment on the MyMindPartner portal if you want to check that out. All right, so here I just wanted to give you a quick pop quiz, see if you were listening. So a patient enters your office with a history of being in the military and marks a 1 for several days on item 9 of the PHQ-9 over the last 2 weeks. Without any other information, what risk level would this patient be considered? Low, moderate, high, or acute risk? If you said moderate risk, you are correct. Both being a military veteran and having an answer of 1 on item 9 of the PHQ-9, either of those things would put a person at moderate risk for suicide. Now keep in mind that every suicide risk assessment should include screening and assessment for history and current substance use or abuse, as this might change next steps or referrals for the provider. Again, the results of the risk assessment drive clinical intervention. The more we know about the risk, the more we can modify the risk, add protective factors, and prevent suicide. Now, I never want to underestimate my audience, so I thought I would give you all a chance to pick out some warning signs for suicide. So I'm going to play a video from the American Foundation for Suicide Prevention, or AFSP website. And as you're watching this video, notice any warning signs for suicide that come up for the father in the video. I do want to let you all know that I've watched this video at least a handful of times, and even though my job is talking about suicide 5 days a week and working on suicide prevention, at least one of those times it probably had me tearing up. So although I think it is a very impactful video, it's also very real, and I just want to give you all that heads up before I press play, that if you need to take a moment and walk away for the next 3 to 4 minutes, you're welcome to do so if you're not up for this video today. So go ahead and skip the next 4 minutes if you would like. Otherwise, I am going to play that video for you.
Pass the ketchup? Dad, are you okay?
Oh, yeah, just stressed out.
Oh, and the melody is sounding so much better. I can play it for you. Wait, where's your guitar?
I gave it to your cousin.
What? That guitar's like your favorite thing.
I don't need it anymore.
Oh, and I saw Henry today. Says he hasn't seen you around.
Uh,
Maybe you should give him a call.
I will. I will.
No, you won't. You said you go.
Have more fun with your friends.
I want you there.
I'm tired. Some days are just better than others.
I think you should go talk to someone.
It's not that easy.
Dad, I can tell that you're hurting, but we can't keep pretending like everything's fine.
I know. I'm sorry.
Have you been thinking about suicide? You can talk to me, Dad.
It's been a tough couple of months.
All right, so thank you for watching that. Although it may be obvious that the father in the video was having difficulty thinking clearly and struggling with depression, for all we know, he may have been having any or all of these thoughts and feelings that you see on the left side of the screen, right? Sometimes people voice these. You may have heard your patient say, I can't think straight, or they're having trouble making decisions. As we hear these things come up in appointments, it can be helpful to do some more questioning to find out how long the person has been feeling this way and how it is affecting them emotionally. It's also important to consider the warning signs and other risk factors that you see on the right hand of the screen. So on the right side, we see that, he was definitely withdrawing from friends and social activities, losing interest in hobbies, and giving away prized possessions. Keep in mind these other risk factors and warning signs that you see here, especially if there has been drastic changes in behavior, such as increasing substance use or having a relapse, changes in appearance, or recent severe losses, just to name a few. Again, remember that the provider, whether primary care or behavioral health, may need to do a little more investigating around the reason why the person is feeling this way or why these changes are occurring. It's also important to ask how the patient is coping with any of these. According to SAMHSA, the protective factors are characteristics associated with a lower likelihood of negative outcomes or that reduce a risk factor's impact. Protective factors may be seen as positive countering events. Some risk and protective factors are fixed, they don't change over time. Others are variable. Behavioral health and primary care providers can help a patient access psychiatric care, and PCPs may even feel comfortable with doing a safety plan with a patient or have some designated staff to help with this. Providers may also support the patient with coping or self-management skills, assisting with means reduction counseling and involving family, and just generally building rapport with the patient to help them feel supported and comfortable with their treatment plan. Other protective factors such as family responsibility, spiritual beliefs, and individual meaning of suicide need to be asked about and discussed further, which is why we suggest that behavioral health providers do a full assessment on the patient's risk and protective factors, as we know primary care may not have the time or space to do so. Now, looking at these and thinking about the video we just watched, the father in the video could have definitely had some protective factors in place, especially related to his family and being a parent, right? But could have asked him some more questions if any of these other things are present in his life, or a person that he is working with in behavioral health could also help with safety planning, accessing psychiatric care, those things, right? Now we will shift to discussing lethal means counseling and safety protocols for removal. I want to start by saying that we are not only discussing firearms here, and that it is just important to keep in mind stashes of medication and other possible lethal means that patients discuss using to try to kill themselves. The statistics are so staggering related to firearm safety, um, related to firearms, that firearm safety is impossible not to address here, especially in Michigan, where we have a lot of hunters and military members. Firearms are the most common method of a lethal attempt, with 56% of suicide deaths in Michigan in 2022 being the result of firearms. So if we know that firearms make up 56% of suicide deaths in Michigan, and only about 33% of individuals are making it to their behavioral health department before they die by suicide, it is essential for primary care to be considering lethal means counseling and having these conversations with their patients as well. So we're also working with them on lethal means counseling and supporting removal. And I just wanted to start by saying that lethal means are not only things that exist in the home, they can be found in the medical office setting. Therefore, it is important that the room that a patient is in is secure if the patient is at risk for suicide. Both the American Psychological Association, or APA, and the American Medical Association, or AMA, advocate for minimizing anything that can be used as lethal means in the doctor's office and other healthcare settings, and recognizes this as a core component of suicide prevention. Office staff should be aware of ligature risks, sharp objects, or medications that can be dangerous for a patient at risk, and try their best not to have access to these in the patient rooms. Every patient should be asked about lethal means availability, as anyone could present down the road in crisis or feeling suicidal. And this is valuable information to have when that is the case. The provider should also check in with the patient about this at future appointments. If possible, remove means from the home and limit access to lethal means. Many things can also be considered as weapons if someone is determined, which is why I want to emphasize the importance of involving family here, as they may be aware of information that you as the provider are not. They also have access to the patient and their environment to help ensure safety. Document steps taken toward lethal means counseling and safety in your office visit notes for yourself and for other providers to be aware of at subsequent appointments. If no handoff is possible or primary care doesn't have behavioral health on site, we do suggest that primary care addresses access to lethal means as well as behavioral health. There are multiple reasons why this is important. One, for suicide prevention; two, child safety; and three, other violence and homicide risks. So there's multiple benefits to harm and lethal means reduction. First, this will hopefully look like a collaborative discussion in which the provider works with the patient and their support people to identify all weapons in the home and any other possible access to lethal means. It is crucial to take some time here to discuss all possible plans and access to means. When able, it's important to gain the patient's cooperation in the process and receive the contact or support person's info from the patient, and sign a release to speak with that individual. If the patient is in immediate danger, consent and agreement from the patient go out the window. So for example, if a patient states that they have a firearm at home and plan on using this to kill themselves that day, The provider may have to reach out to the emergency contact or authorities, even without the patient's consent, to ensure that the patient is not in immediate danger of harming themselves or someone else. Next, establish an individual plan for means removal and safety. If the patient agrees to weapons removal, contact the support person with the patient in the room to implement a plan for weapons removal. Secure agreement of the support person to call back and confirm weapons removal. Instruct the support person to speak directly with the provider. And do not direct patients or the support person to bring any weapons to patient care sites. There is no research to indicate whether it is safe to return firearms to the home after removal. If a patient refuses removal of weapons, but agrees to allow communication with the support person, educate the support person regarding the risk of weapons availability and the need to continue to encourage the patient to allow means or weapons removal. It can be helpful here to discuss the treatment plan and solicit feedback about safety with the support person if possible. And if the patient refuses removal of weapons and does not agree to allow communication with a support person, which is possible, especially if they are not in immediate danger, we always want to educate the patient regarding the risk of suicide with weapons availability. Ensure that the weapon removal is discussed at every encounter and that the conversation continues to be documented. And you can always encourage the use of a gun safe or medication safe. Ideally, we would like a provider to reevaluate risk at each meeting and always document this in the patient record. Here are some further considerations for firearm safety. 90% of suicide attempts with firearms result in death. This is why it's so important to continually discuss lethal means removal with patients who are at risk. The fact about the odds of dying by firearm being 3 times higher may be helpful to use with patients if they are considering buying a firearm, which they do tell us sometimes, but may not go over as well when you are talking to someone who is already a firearm owner. So read the room and know your audience with this. And you want to keep in mind that males, especially older males and veterans, are at higher risk of dying by firearm-related suicide. On our My Mind Suicide Prevention Hotline handout, which we'll discuss here shortly, there is a line specific for veterans. If you call 988 or the 1-800-273-TALK and press 1, you can speak to someone who specifically works with veterans, and especially if they're having suicidal thoughts, but also if they just need someone to talk to, they can call that number. It is helpful to have a standard phrase related to lethal means counseling and to talk about weapons removal being especially important for people who have children in the home. For example, you may preface with saying something like, I know this sounds like a bit of a weird question, but this is something we ask everyone. Do you have any firearms in the home or access to firearms? We ask this for your safety and for any others in the home, especially children. And you might let them know that you will be checking in with them on this at future appointments. For people or youth who have a firearm in the home that is not theirs, ask more questions. Find out more about firearm knowledge and placement or others who could be in danger in the home. You can get creative regarding bringing in support people to confirm safety and or talk to parents or guardians, which we have heard in the trainings that both primary care and behavioral health are already doing. So good job. Prioritize harm reduction, practice having the conversation, and consider popping in for some My Mind office hours coming up to support, get support on best practices when having these conversations with patients. And at the bottom of the slide is the website for Lock to Live, which is a great tool that patients can use on their own to explore ways to reduce risk or harm of harm with a firearm or other possible lethal means. So it takes the patient through considering what means are available and how they can reduce harm or put those things in a place that is not accessible for them when they are in danger. And do keep in mind, some people have stronger attachment to their firearms than others, and that is important to consider your language and timing when you're having the conversation about harm reduction. And just be sure not to impart your bias on the situation. All right, here is a time if you'd like, you could take a 5-minute break. So go ahead and pause if you'd like. Otherwise, I'm going to keep going. So you'll see a quiz here. I'm going to ask you a question here. So lethal means counseling is supportive of suicide prevention, other violence and homicide risks, child safety, or all of the above. The answer here is all of the above. So we know lethal means counseling is supportive of all three of those things. So now we will transition over to talking about patient self-management strategies and how to best support patients outside of their appointment. Although everyone's social support system tends to look a little different, we know that involving a family member, significant other, or even someone like a roommate or friend or loved one in a patient's care has the potential to save lives. We will also discuss how patients gain support from others outside of the patient's usual social support system. Let's talk about creating a community of healing. We recognize that involving loved ones can feel uncomfortable for some providers, especially if this is not your usual practice. We worry about patient privacy and HIPAA, and sometimes worry that involving family might cause more harm than good. Today, we will debunk that myth. There are many positive reasons for involving the patient's social support system outside of the healthcare team. The truth of the matter is that clinicians are poor predictors of suicide risk. Recent research demonstrates that suicidal ideation alone is not a reliable basis for suicide risk determination. The collateral data or information from family, significant others, or other social support people can aid the clinician in determining severity of risk, as well as chronic suicide risk. Involving the patient's social support system can be therapeutic, and their involvement may lessen claims of malpractice. When we talk about a patient's social support system, this can mean their immediate family or significant other. It may also include a friend, roommate, or a distant relative, like maybe an aunt or a nephew, for example. This can be anyone that a patient feels is a safe support and that they trust to speak with their provider. Often our strongest social support system is the family we choose, so it is important to talk to the patient about who is best to involve in their care and who can be the most supportive of the patient's treatment. Involving the social support system may look different for each patient. For example, people who are part of a stigmatized community, including those who are LGBTQ+, may have lack of support from their biological family, but often have a strong support system of friends that are considered family. Now, when considering involving the patient's social support system, keep the following protocol in mind. Support system involvement should be made anytime an individual is considered high or acute risk for suicide. This can also be helpful for patients deemed moderate to low risk and really depends on the conversation that the provider has with the patient and the provider's clinical judgment. Collaborate with the patient on who is best to involve in their care and obtain informed consent in the form of a signed release or verbal consent if the patient is on the phone or being seen for a virtual appointment. Of course, always document written or verbal consent in the chart. If the patient refuses to include anyone from their social support system, be sure to document this in the chart as well. Always discuss with the patient what you plan to share with their social support people. Provide the patient's support person with appropriate information about the patient's treatment and plan of care, as well as any tools or resources. For an adult patient, you can provide the My Mind handout called Understanding and Helping Someone Who is Suicidal to their support person, or for a PEDS patient, providing the handout Preventing Suicide Tips for Parents to their guardian or adult. And those both can be found on the My Mind partner portal under the document library. And we actually do have those patient and support facing documents in multiple different languages too. Involving the social support system outside of the healthcare setting is not a one and done. Think of the social support system as a part of the treatment team and that there will be ongoing discussions related to patient care. We also want to emphasize here that not all patient relationships are healthy ones. Some are not safe or appropriate to include in the patient's care, so it's important to ask thoughtful questions about the patient's safety with these individuals. For example, if there are individuals that the patient feels may use their health information to be malicious, this is not a good person to involve. At times, a patient may not even realize that this person may not have their best interest in mind, and we don't find that out till later. If you identify that a support person is unhealthy, it is important to address this with the patient to explore healthier areas of support or further referrals or resources that are needed. Involving a support person in the patient's care can benefit the patient with further support outside of their treatment team and normal clinic hours. It can also be an advantage to the provider and their care for the patient. The social support person can assist with lethal means removal, monitoring patient symptoms and severity, promote engagement in care, adherence, and healthy activities. They can also help the patient to learn about and better understand their diagnosis. Sometimes it can be useful for a support person to attend a primary care or behavioral health appointment with the patient. This can help that social support person be aware of the treatment plan and where they can provide additional support. They may also be able to provide supplementary information about the patient and their health that the provider may not get otherwise. When people are depressed, they may feel like they are walking around in a fog and have difficulty remembering things. Although we never want to underestimate a patient's ability to manage their own care, having a social support person in an appointment to obtain and provide key information may be extremely helpful. At times, it's difficult for patients who are depressed to get out of bed and complete hygiene and other daily activities. So it's understandable that they may be struggling to get to their appointment, take their medications, or just be present during those times. Involving support people can be a game changer in these situations. If the patient feels suicidal, their support person can also support the patient with calling 988, calling 911, and/or taking them to the nearest ER. Family, friends, or loved ones can update the patient's treatment team if the patient goes into the ER or inpatient. This can be really helpful because as providers, we are not always privy to that information, especially if the patient goes to an ER or is admitted in a hospital system outside of our own. I'm sure most of you have probably had experience with working with patients that have a lack of social support. There can be many reasons for this, but for myself as a therapist, it's an indicator that the patient may need added support and resources. It's especially important that patients who do not have supportive friends, family, or loved ones feel supported by their treatment team and that the treatment team works together to support the patient. In my mind, we talk about the two-prong approach with primary care and behavioral health partnering to support patients. But for patients at risk for suicide, coordinating with other specialty providers may also be helpful. This might include the patient's providers in pain management, endocrinology, or oncology, those different kinds of departments, and maybe a patient who benefits from working with case management in any of those departments. Providers can encourage participation in local or virtual support groups and community organizations. Even something like volunteering can be a positive social experience for a patient that can help them feel like they are part of their community. On the next few slides, we provide some resources for further social support. Some of these serve as adjuncts to treatment, with research to suggest that they improve patient care and outcomes. Referrals to crisis and suicide prevention hotlines and support groups can also play an active role in supporting patient self-management. So individuals can call the Suicide and Crisis Lifeline by dialing 988 or the 1-800-273-TALK number that was used before 988. And folks can also text 988 to receive support as well. There is an online chat for 988 too. There will be a QR code at the end of this presentation that takes you to all three of those. And this line provides confidential emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week across the United States. 988 is for anyone experiencing behavioral health related distress, whether it's thoughts of suicide, mental health, or substance use crisis, or just in emotional distress in general. It's a national network of over 160 local crisis centers, combining custom local care and resources with national standards and best practices. People can dial 911 or 988, sorry, if they are worried about a loved one who may need crisis support. So support people can also call 988. And people can call this number and receive support in multiple different languages. So when you call 988, it will prompt you to press 2 if you would like to speak to someone Spanish speaking, but there's also interpreters that speak multiple different languages on that line as well. 988 does provide support to people who are LGBTQ+, but we also wanted to add the Trans Lifeline here as another free hotline for transgender people to use who are experiencing a crisis. This includes people who may be struggling with their gender identity and are not sure if they are trans. You can let the patient know that even if they are not sure if they should call, they can still call if they are needing support. The Veterans Crisis Line connects veterans in crisis and their families with families and friends with qualified caring Department of Veterans Affairs responders through a confidential toll-free hotline, online chat, or text. Veterans and their loved ones can call 988, press 1, chat online, or send a text message to 838-255 to receive confidential support 24/7, 365 days a year. So although you can text 988, there is a specific text line for veterans. That's that 838-255 number you see here on the screen. There is also support for people who are deaf and hard of hearing on that line. Linking patients to community resources is crucial to successful management of acute and chronic behavioral health symptoms and effective mental health care. The National Alliance on Mental Illness, or NAMI, is a great resource for all individuals that are impacted by mental health. NAMI does provide support and resources on the national, state, and local level, including local virtual and in-person support groups that individuals can attend. Websites are included here on the screen, and we do have a handout on the MyMind Partner portal specific for NAMI support groups. We did want to provide some other support group options for providers to refer to, as well as utilize themselves if feeling that they need further support. The Depression and Bipolar Support Alliance, or DBSA, has some good educational information, resources, and online support groups for individuals managing these diagnoses, as well as their support people. The Anxiety and Depression Association of America website states that they are triumphing through science, treatment, and education, and offer educational information, a lot of times in webinar form, as well as some peer-to-peer support groups. And I did include websites to find meetings for Alcoholics Anonymous, or AA, Narcotics Anonymous, or NA, as well as Medication Assisted Recovery Anonymous, or MARA. Also included here are Codependence Anonymous and Smart Recovery. So AA, NA, and MARA are meant to support people who are trying to stop substance use. Um, some of those groups are open and family and friends can also join. Smart Recovery is another group that helps people to stop using substances, but has no religious aspect at all, and is specifically based on science and recovery. And then Codependence Anonymous can be a group that patients or their loved ones can attend to make sure that they are working towards having healthy relationships in their life. We do have a handout on the My Mind Partner portal with these and other various support groups that may be helpful to those who are survivors of suicide, as well as individuals managing peri and postpartum depression, grief and loss, chronic pain, and cancer diagnosis. We also included Henry Ford's CARE program, which has a lot of good resources for caregivers and is open to individuals even if they are not receiving their care at Henry Ford Health. And here I just wanted to highlight some of those organizations and websites that support individuals who are survivors of suicide, including Alliance of Hope and Kevin Song. They provide support to survivors of suicide attempt, as well as loved ones who are affected by suicide. The Compassionate Friends specifically provides support to families after a child passes. And New Hope Grief Support Community has a variety of ongoing loss-specific grief support. And there is no cost or pre-registration required to attend these grief support groups. And again, these are also included along with the websites and information on the last slide in our support group handout on the My Mind Partner portal document library. So we continue our training today discussing further patient self-management strategies. Giving patients a central role in determining their care can help foster a sense of responsibility for their own health. Patients need information to become effective managers of their health. With support, patients can learn to take better care of themselves to keep chronic illnesses under control. And this extends beyond physical health, as we know that patients' physical health often suffers along with their mental health and vice versa. Next, we will talk about some strategies that can support patient self-management. The hope is that you will be able to walk away with at least a few different ideas and resources of ways that you can empower the patients you work with to manage stressors and symptoms related to mental health. Keep in mind that healthy self-management can include working with patients to identify coping skills and healthy activities like you see here on the screen, such as gardening, painting, meditating, reading, these kinds of things. So using a collaborative approach, healthcare providers and patients can work together to define problems, set priorities, establish goals, and create treatment plans while often solving problems along the way. Now, this does not mean waiting for the patient to ask for help, as we are all aware of the stigma related to mental health. In order to meet this need, it is important for patients to have information about suicide prevention, information regarding their behavioral health diagnosis, a variety of self-management tools in a variety of formats. Some we discussed already and we'll discuss here in a moment, and an introduction to cognitive problem-solving approach. We do have handouts on the My Mind Partner portal with information on problem solving, a nice problem solving handout that you could work with a patient on or give the patient to work on their own. And we also have some dialectical behavioral therapy or DBT handouts for our behavioral health participants. Those can be found under the helpful links page in the My Mind Partner portal. And My Mind recommends starting the discussion of self-management strategies at the patient's first appointment by talking about healthy activities that the patient has engaged in the past or is doing currently. As providers and patients, we often underestimate that patients already have many answers as to what helps them feel better. However, they may be lacking motivation or dealing with barriers that may be environmental or social in context. We included a handout with self-help books on the My Mind Partner portal for you to check out, and share with your patients. We are looking to add more to that list down the road. One book on the list that we would like to suggest is Mind Over Mood, which is a workbook based on cognitive behavioral therapy techniques. So behavioral health clinicians can suggest that patients read and complete the exercises in the workbook and can discuss the results with their behavioral health providers in their therapy appointments, especially if their provider is familiar with or already working with the patient on cognitive behavioral therapy techniques. Now, I'm just going to mention this briefly, but you'll have the slide to go back to. YourLifeYourVoice.org has a great handout for helping someone create a hope box. So a hope box is a nice intervention that patients can use, pretty much just finding a big envelope or a box and putting things in that box or envelope that cause them to feel hopeful, that cheer them up, that give them a little bit of relief from the pain that they're dealing with. So you can check out that website and that handout there and check out this slide later. And just wanted to mention this as a nice thing that you can work with patients on creating and using. Maybe putting that box like in a next to their bed or having it somewhere easy where they can take out the materials and go through them mindfully and hopefully provides them with some hope. And now we're going to shift into safety planning. A safety plan is a written set of instructions that a patient and clinician create as a contingency plan should the patient have thoughts of harming or killing themselves. So different than safety contract. We know that safety contracts are not evidence-based for suicide prevention, but what we do know is that safety planning is. So my mind suggests behavioral health staff complete a safety plan with any patient at or above moderate risk for suicide. So anybody moderate, high, or acute risk. Although we know that timing does not always permit a full safety plan to be completed, or patients may disagree with completing a safety plan. So while a full safety plan is ideal and includes all the elements you see here on the screen, the top most important things for primary care and behavioral health to keep in mind are that the patient has the 988 helpline and text line number. The patient's emergency contact and support person information is up to date in the EMR. This chosen support person is trusted to ensure that the patient is safe. Therefore, they should be local or close in proximity to the patient. If no support person is available, encourage the patient to find a distraction, a healthy distraction, like maybe listening to music that cheers them up or watching cartoons that help them feel better, and go to a place where the patient is not alone. You can call the police to do a wellness check on a worst case scenario. Of course, this is last resort as it can make the patient anxious or not want to return. Support with removal of lethal means as much as possible, and providers should encourage the patient to go to the emergency department or call 911 if the patient is in danger or is planning to do something to hurt or kill themselves between appointments. Per the research, we know that safety plans reduce suicide risk by 20 to 25%. In a recent article co-authored by Angerhofer and the MyMind co-directors, this was found to be true when paired with suicide risk screening using the PHQ-9 item 9 to identify risk. According to some research gathered by Rainbow et al. 2024, suicide-related coping is a specific set of skills describing the knowledge and confidence to use self-guided and external support systems to manage and control suicidal urges. These skills may directly reduce future suicide risk as suicidal ideation, depression, and hopelessness appear to be lower in those with stronger suicide-related coping skills. Use of internal coping skills like self-guided cognitive direction activities has been shown to reduce suicidal ideation in real time. And stronger external coping, like seeking support from others, has been associated with lower levels of two major interpersonal drivers of suicidal ideation, thwarted belongingness and perceived burdenness, which Thomas Joyner talks about in his research, and greater controllability of suicidal urges. So safety plans work. The safety plan template is available via the My Mind Partner portal in our website. And again, patients can complete a safety plan on their own via the Suicide Safety Plan app. Over the next few slides, I would like you all to complete a safety plan for yourself today. If you have never done this with a patient, this can be a good opportunity to see what this is like. So go ahead and take a moment to take out a piece of paper and pen or pencil, or even just open up a Word document or your notes on your phone so that you can put your answers down. As a note here, it is ideal for the provider to complete the safety plan with the patient and then provide that safety plan to the patient, as it is important for the provider to be aware of the answers and ensure that it's actually being filled out. So first, I want you to start by putting yourself in your patient's shoes. Imagine that you are a patient that is very depressed or emotionally struggling. You may have difficulty completing this. For some patients, it may be difficult for them to even brush their teeth, let alone want to go for a walk. Having verbiage to normalize this experience and support the patient in doing the best they can is very important here. So I'll walk through the first couple steps as you fill out your own answers. So I would usually start the conversation out with something like, I know you had mentioned having thoughts of not wanting to be here, and I think it would be helpful for us to do a safety plan today. If the patient declines, I would usually try to counteract that with letting the patient know that this is normal practice and that completing a safety plan can be helpful and therapeutic, even when someone is not in danger of hurting or killing themselves, and that it can be used just to think through things that can help them feel better. I also want to let them know that I can help them along the way, and it shouldn't take very long, about 10 minutes or so. So step one is recognizing your warning signs of a crisis developing. If the patient is having difficulty finding an answer, I say something like, when you have felt extremely sad in the past, what thoughts or feelings or behaviors did you notice in yourself? So you can change out that extremely sad with anxious, angry, or suicidal. But something like, when you have felt suicidal in the past, what have you noticed in your thoughts or feelings or behaviors? So just asking in that way about those warning signs. You can also say some examples are, and then read examples off of the form. If you are familiar with the patient and are aware of any of their warning signs, you can make a suggestion like, I know you said in the past that you feel like your temperature goes up when you're feeling angry. Do you want to add that here? So if you haven't already, write down your top 3 warning signs. Step 2 is naming things that you can do to help yourself feel better or that can be self-soothing. So next, can you name a few things that help you feel better or give you comfort? And feel free to pause the video if you need to. Again, just normalizing that this might be difficult for the patient is important. You must validate the patient for trying and doing the best they can. If the patient is really struggling with this, you can read off the examples or give them some ideas for self-management, possibly by providing one of the My Mind handouts or some resources. Keep in mind that the answers here should be healthy and should not include drinking alcohol, using drugs, or other activities that patients have difficulty managing, such as gambling. So you will probably have a patient suggest putting drinking a glass of wine on here. I always say let's try to think of something else to put in that spot as much as possible. So hopefully you got your answers for the first two. Feel free to go back and again pause the video if you need to. For the third step, I want you to think about and write down your 3 most important reasons for living. I know this is a big question, so do the best you can. It is important here to recognize if the patient is struggling with completing step 3, and this can be a warning sign or indicator that the patient may need further support. If the patient cannot think of any reasons for living, you can ask them, what helps them to keep going or what motivates them to attend their appointments or go to school or go to work, right? It can also be a small thing and may not be what you or I would think of. So if they want to keep living because they want to go to the park every week and feed the birds or meet with their friend to play chess, we're adding that on here if they feel like that is an important reason for them to live. For step 4, consider positive things that you can focus on in the moment when you are feeling overwhelmed, depressed, or having suicidal thoughts. For this one, I often name off the examples that are provided and usually say, these can be anything like a nice memory, something positive that happened to you, something good in your life, or people who care about you. Just do the best you can. So go ahead and write those down for yourself now. It may be helpful to give those examples one by one, as this is probably the toughest question of them all and can be overwhelming for patients. If the patient is having difficulty thinking of anything for step 4, for example, maybe they feel like they named everything off already in the last 2 questions. 1, you can let them know that they are allowed to do repeats. There's no safety plan police. Also consider maybe making a suggestion, like using guided imagery if the patient is struggling with step 4. Again, just being creative here. Maybe it's thinking about a thank you that they received from someone or someone acknowledging their hard work. Completing a safety plan with a patient can be the time that you let them know that you have been listening, and you can possibly make some suggestions on these if you know the patient and you have that rapport built. In turn, safety planning can also help a provider build rapport and increase medical trust. So hopefully you have been able to write down your important reasons for living and a few positive things that you can think about in the moment. In step 5, I want you to think of your top 3 people that you would call if these strategies do not work or if you are in danger of hurting or killing yourself. So who would your number 1 go-to person be? And then who would the second or third person be? So go ahead and think about this and write down their names and numbers now. I always suggest patients look up the numbers and write down the numbers as well, just so they have them handy on the safety plan and so that the provider has them as well. Again, like step 3, it is important to recognize if the patient is struggling with identifying others in their life that they can reach out to for support. This is another indication that the patient might need further support and resources, possibly referrals. It is important that patients choose safe, supportive people here for obvious reasons, but also because we want them to pick people that the patient will actually reach out to when they are in crisis. Although the patient may pick individuals that may not that we may not consider, such as a roommate or a coworker, it is most important that they still feel that they will feel comfortable and safe reaching out to these individuals and that they are supportive to the patient. Step 6 is to be completed with the therapist and psychiatrist name and numbers, as well as the suicide prevention hotline and text line number, that 988. And step 7 should say something similar to what is on the screen here, stating if the above steps are not helpful and I feel I may take my life, I should go to the nearest emergency room or call 911. So now you have gotten a chance to see what a safety plan looks like and how to fill one out if you haven't already. As the behavioral health provider partnering with primary care, it is important for primary care to know where this information can be found in the patient's notes or be alerted of safety plans when they are completed with behavioral health and vice versa. Some important things to keep in mind as you're supporting patients with safety planning is that the provider should talk to the patient about what to do with the plan. Providers can make multiple copies for the patient to keep in different places, such as one at bedside, one in their purse or wallet. And it's important to talk about when to use a safety plan. Maybe it's to review if they feel hopeless or suicidal, and reminding the patient to follow these steps. It may be helpful for a significant other or close loved one to have a copy and understand its purpose. It's also vital for behavioral health providers to follow up with the patient regarding whether the patient is using it, if it's helpful, or if it needs to be updated. So good job completing a safety plan for yourself today. And now you have that to use if you are struggling in the future. So hopefully that can be helpful if you need it. Now, just a couple slides here talking about carrying cards and letters. So from the research, we are aware that sending carrying cards after an appointment is an effective strategy for reducing suicide, and this has been replicated in multiple well-controlled studies. This can be a low-cost strategy, especially if sending messages digitally via the EMR. And this can also include a letter via snail mail or a call after an appointment or discharge. My mind suggests using caring follow-ups and outpatient ambulatory care at the time of the first missed appointment. At any time a patient is at high or acute risk, or anyone that you feel would benefit from a follow-up. We always say, when in doubt, reach out. That's why we have a caring card letter and postcard template that is simply just to reach out to the patient, a little more general, to let them know that you care and want to provide them with the 988 call and text line. We also suggest providers in inpatient or residential units send a caring letter on the day of discharge. Here you will see an example of a caring card that is available on the My Mind Partner portal. We also have letters specific to those other 4 scenarios I just mentioned. So feel free to copy and paste the information to print on your practice or health system letterhead. And if you need Word documents to help with this for sending out via snail mail, just reach out to us and we can get you those. And notice here that the verbiage in the letter validates the patient's situation and emotions and lets the patient know that you are reaching out because you are concerned and care about them as their provider. It should include the clinic number as well as an after numbers clinic hour if after hours clinic number if available. And of course, it should include that 988 text and call line. So at this point, you have screened the patient in your primary care office and have asked the patient if they have any plan and intent to kill themselves, and possibly had the opportunity to consider some risk and protective factors for the patient. You also have information on some brief interventions that can help reduce the likelihood of suicide attempt. So what's next? Let's talk about triaging patients who are in crisis. So in this first scenario, you are on the phone with a patient that has active suicidal ideation with plan or intent. So I'll give you a moment here to think about how you would support this patient in this situation, given what we just talked about. All right. So for this patient, we want behavioral health providers to confirm a full name, contact number, and address where the patient is located in case you are disconnected. Ask if there are family members or support people there with them and get them involved for further support. Ask the patient if there are any weapons or other means of harm in the home. Inform the patient and their support people that you will call 911 and send help to their location. Always do this after confirming their location. Now, you or designated staff should maintain contact with the patient until police or EMS arrive, so you might need to involve other staff here, either asking them to stay on with the patient while you call 911 or vice versa. And when speaking with the police, note the officer's name, badge, and identification number and time you spoke with them so that you can document this in the EMR and in case you need to follow up with them in the future. So really just trying to support the patient to get to the ER as soon as possible for that psychiatric evaluation. Having a patient with suicidal plan and intent in person may be easier to manage if you can have some support staff nearby to assist. However, this can also feel very rushed and stressful when staff are trying to maintain the clinic flow while a patient is in crisis. First and foremost, stay calm and breathe. Thank goodness that that patient got to their appointment today and they are still living and breathing in front of you. So as we're thinking about this patient who has suicidal ideation with plan and or intent in the clinic setting, is there anything that you would do differently for this patient? So I'll give you a moment to think about that in comparison with our first scenario. So place the patient in a secure and supportive environment, similar to staying on the phone with the patient. You also want to make sure, and asking about lethal means, you also want to make sure that they're in a supportive and secure environment and that we don't leave the patient alone. Ask if there are family members or support people there with them. Sometimes support people might be waiting in the lobby or in the car. Always remove any immediate means or self-harm, like pill bottles, sharp objects, ligature risks, and discuss the plan with the patient. So dispositions may include calling 911 to send the patient to the emergency department for further evaluation, or when possible in behavioral health, you may be able to directly admit the patient to an inpatient department. So that is another option there. Other dispositions would depend on additional risk assessment. So if behavioral health determines a less restrictive level of care is indicated, maybe like partial hospitalization or PHP, or an intensive outpatient program or IOP. If the patient has a plan but no intent, this may be a patient that's better suited for IOP or PHP, which really depends on their protective factors, which would be assessed by psychiatry. Never forcibly restrain or physically prevent a patient refusing evaluation or trying to leave against medical advice or AMA. Call security or 911 and report that the patient left AMA and request a home safety check. If the patient attempts to leave AMA, just be persistent, trying to get them to stay with your words, not physically. And if they do leave AMA and you can attain any helpful information for police, like license plate number, make and model of car, can be helpful. In this situation, primary care may be reaching out to behavioral health for an emergency consult or may send the patient directly to the ER. And ER providers would like for the provider or nurse or family member to complete a petition. However, it's not necessary. And we know that MDs and DOs will most likely be providing a certification. In this last scenario, we have a patient with passive suicidal ideation, but is still at risk. This can feel like a bit of a gray area for providers, even in behavioral health. The importance here is for the provider to do the best that they can to keep the patient safe and avoid hospitalization if possible. So think about how you would support a patient with suicidal ideation with no plan or intent that answers 1 on that PHQ-9, item 9. So I'll give you a moment to think about that before I bring up some points here on the screen. All right, so this person might benefit from a referral to psychotherapy or psychiatry. If you're a psychiatrist seeing the patient, maybe you would refer to psychotherapy or vice versa. And remember to keep your behavioral health and PCP partners informed of the plan for this patient. My mind suggests using the collaborative care model here, but this could vary depending on the structure of your organization. Confirm the patient's home address and patient phone number and emergency contact is up to date. Identify support and patient's plans for the upcoming days, and involve support people if the patient is agreeable. Complete a safety plan with the patient, or you can recommend that they complete one on the Suicide Safety Plan app. And remember, current research indicates safety contracts do not have validity. You want to do safety planning, which we know is evidence-based. Always provide the patient with self-management tools, including the suicide hotline and text line number, which are listed here on the screen, as well as any of the other things we suggested earlier. Persuade the patient to get help if symptoms worsen, and strongly encourage the patient to reach out for help and not hurt or kill themselves before their next appointment with primary care or behavioral health. So not safety contracting there, just really encouraging them to reach out for help if they need it. And if the patient is on the phone, if possible, schedule the patient for an in-office or video visit with a provider as soon as possible. If access to behavioral health is limited and the behavioral health provider is unable to increase frequency of appointments, it might be helpful to coordinate with primary care to have the patient come in sooner, to check in with primary care, and continue to provide those warm handoffs and messages to update primary care to support patient safety. Again, it's important to consider, is the patient future oriented, and does the patient have people outside of the provider for support? Discuss with the patient if it is necessary to contact the patient's social support team and update them. And again, it's nice to have a robust set of self-management tools and ideas, which is why on the My Mind Partner portal, we have that list of support groups, some books that could be supportive, safety planning template, those different things we discussed earlier. And digital resources can also be helpful, like the Suicide Safety Plan app or the website for the American Foundation for Suicide Prevention. Again, you could suggest that they create a hope box and do things that can help them feel positive or give them hope. On this slide, you will see our recommendations for psychiatric referrals and timeframes. You'll see that hospitalization is recommended for patients at acute risk. If a less restrictive level of care is indicated by outpatient psychiatry, such as POP or IOP, then rationale should be clearly documented. We suggest behavioral health providers seek a same-day second opinion if unsure of treatment intervention, and that lethal means counseling, family support involvement, and safety planning should always be completed if the patient is not going directly to the ER. Patients at high risk should have psychiatric evaluation within 48 hours and initiation of somatic treatment, such as starting a psychiatric medication, as well as a referral to evidence-based treatment like CBT-SP for suicide prevention. DBT is also recommended. This patient might also benefit from receiving a higher level of care than outpatient, like IOP or a chemical dependency program, depending on their risk and protective factors. Psychiatric admission for a high-risk patient may be needed if the patient has additional factors that affect safety, such as a lack of any social support or compound risk. Patients who present to behavioral health with moderate suicide risk should receive a psych eval within 7 days. Again, this could be a patient who may continue to be seen in outpatient setting or receive care via collaborative care. They also might benefit from IOP or substance abuse treatment if needing more intensive care. And we suggest using your clinical judgment regarding making a referral for patients at low risk and discussing with the patient their psychiatric needs. Of course, low-risk patients are great candidates for collaborative care and could have psychiatry support via that collaborative care psychiatric consultant who works with the collaborative care team. Similar to referring to psychiatry, we also have some recommendations for psychotherapy. We suggest that those in acute risk do require psychiatric evaluation. If they are admitted, we suggest that they are seen by a psychotherapist within 72 hours. Psychotherapy appointments after discharge for acute risk, and then psychotherapy appointment within 72 hours of the appointment for a high-risk patient. We suggest psychotherapy appointment within 5 days for a high-risk patient and 7 days for moderate risk. Again, low risk will depend on psychiatric evaluation related to the patient's current needs and response to treatment. So we actually have a typo here on the screen. It is supposed to be within 72 hours for acute risk, either as soon as the patient is released from being admitted from the hospital, or if they don't get admitted to the hospital, we would want them to be seen by psychotherapy within 72 hours and 5 days for high-risk patients. So sorry about that. Just wanted to make a note of that. And the goal is really here for primary care and behavioral health to partner to provide brief interventions and resources, which is why it is important for PCPs to know care pathway recommendations and be able to do some of the intervention with the patient, and we suggest that primary care staff be able to support these same brief interventions that we discussed today in their office. So earlier in the training, we provided recommendations for scenarios for patients with active or passive suicidal ideation and started talking about care pathways for suicidal prevention. Now we'll discuss what a care pathway is and how you can start to formulate a care pathway for suicide prevention or strengthen the suicide prevention care pathway at your clinic. Our co-director, Dr. Amadani, states that a care pathway is the journey that a patient takes when accessing the healthcare system. A suicide prevention care pathway is an intervention and visualization of a patient's journey in the healthcare system that begins with the patient being screened for suicide risk in primary care and behavioral health settings and provides recommendations for next steps for the patient and providers involved. The suicide prevention care pathway promotes suicide risk screening at every patient encounter and provides recommendations to promote safety throughout the patient experience with the goal of reducing suicide. It supports the care team with guidance on best practices and next steps related to the patient suicide screening. Facilitates communication among team members and collaboration with family and support people outside of the healthcare team. It defines roles of the multidisciplinary team as well as resources like we discussed earlier. Now, our current program is working with providers in outpatient or ambulatory behavioral health and primary care for the adult population. We know that we are planning to expand to the PEDS population for our behavioral health and primary care outpatient folks, but we also want you to know that as we continue to extend throughout the state of Michigan, we will also keep in mind urgent cares and inpatient or ERs, PHPs and IOPs, which are also at times part of the suicide prevention care pathway for our patients. So although we just discussed them here and are not working directly with those folks at this time, we are considering that as we expand the MyMind CQI. So essentially, your clinic suicide prevention care pathway is your specific suicide prevention practices and protocols mapped out in a way that's easy to view, use, and reference for all staff, is tailored to your clinic and patient population, and utilizes evidence-based approaches. And your care pathway will include transitions in care and consider patient safety during these transitions, including access to protective factors. Now, we know that you might just be formulating your clinic's suicide prevention protocols and processes, or maybe you're in the process of getting them solidified to share with the team. So as you make strides to increase your knowledge and understanding regarding suicide prevention in your clinic, we want you to keep the following questions in mind that you see on the screen. Even if you already have a protocol and care pathway in place, it's good to check in with other staff to make sure that they are aware of the protocols and that everyone is on the same page. It's also good to find out what's working and what's not working, and if any of these processes need to be tightened up. For example, identifying missed opportunities for screening and making adjustments to ensure that more patients are screened. And we'll be talking about how you can do that in the next module when we talk about the PDSA. Behavioral health and primary care should include consideration for each other's roles in suicide prevention. These care pathways should flow from one into the other, as this is what behavioral health care pathway would look like once referred to from primary care. Behavioral health and primary care may create an integrated care pathway for suicide prevention if using collaborative care as well. So here I will walk you through the suicide prevention care pathway over the next few minutes. So the suicide prevention care pathway starts when a patient presents to behavioral health, possibly as a referral from primary care. The patient is then screened for suicide risk using the PHQ-9 and focusing specifically on item 9 to stratify risk, screening every patient every time. The provider will then complete the zero suicide risk assessment at each appointment. Behavioral health should then complete lethal means assessment and counseling and consider what other brief interventions or resources would be helpful for the patient. And we have those at a quick glance here on the screen. I know it's small. We actually have a handout or PDF that has this care pathway, the suicide prevention care pathway for behavioral health. So you can see that a little bit closer, but it includes providing 988 crisis, suicide and crisis lifeline, and self-management resources like safety planning, providing community referrals, and involving loved ones. You can see the care pathway here that we have included risk factors for each risk bucket, which behavioral health will be aware of from completing the suicide risk assessment and can follow the recommendations based on the patient's risk level. So here we see that for an acute risk patient, we suggest same-day psychiatric evaluation. Most likely this patient will be going to the emergency department. If not, rationale for that, for not sending the patient to the ED should be provided. If psychiatric evaluation and comprehensive risk assessment is completed that same day and results warrant a less restrictive level of care, that patient might be a good candidate for IOP or PHP. And for acute patients, we also want to consider what brief interventions could be helpful, like lethal means access, and need for removal, collaborative safety planning, support system involvement. For all of these, once the referral is made, whether it's to go to the emergency department or another program or outpatient, we always want to update the primary care doctor about their treatment and continue to keep that line of communication open, as well as follow up with the patient. Patients with high risk factors should receive psychiatric evaluation within 48 hours. This can be completed by an outpatient psychiatrist or collaborative care psychiatric consultant. Evidence-based somatic therapy can be initiated via an outpatient psychiatrist, and level of care may vary here according to risk and protective factors. We have some suggestions here on the screen for different possible dispositions for this patient and referrals. We suggest that a patient receives a psychiatric evaluation within 7 days if they are at moderate risk. And next steps would depend on the provider's clinical judgment and discussion with the patient. So we also suggested some options here for the moderate risk level. Again, this might be a patient that is a good candidate for collaborative care or outpatient psychiatry. And remember that using evidence-based treatment and prevention strategies to support lowering risk is important. So keeping in mind safety planning, CBT, SP, DBT, problem-solving therapy for this patient. Those who are at low risk, next steps would really depend on the provider's judgment and discussions with the patient. So we also included some suggested options here. Again, for this patient, self-management strategies are really important to support the patient in between appointments. A patient who is low risk, although they might be working with collaborative care or outpatient psychiatry, is not going to be seen as often and is more likely to be complete therapy or psychiatry sooner. So it's good to start working with them on patient self-management strategies so they have something for support in between appointments and once they have completed therapy. Similar to the behavioral health suicide prevention care pathway, we have also created a primary care suicide prevention care pathway. So that might also be helpful to check out to understand what we suggest for primary care. Again, using that item number 9 of the PHQ-9 to stratify risk and give some guidance on next steps for primary care. So here we have our key takeaways for our training today. Screening for suicide risk, providing lethal means counseling, and involving a support person can promote suicide prevention and can benefit both the patient and the provider, and possibly even the support person involved. Providing self-management resources are key to the patient being able to maintain mental health and sustain management of suicidal ideation. Collaborative safety planning gives the patient something to reference outside of normal clinic hours. Safety plans should always include the suicide prevention hotline and text line number and should be reviewed at each session. Keep in mind that caring cards or follow-ups are a simple but helpful tool that providers can send after an appointment and should include multiple options to access care if needed. And all of these aspects, including supporting the patient, supporting patient safety during transitions in care, and working with other providers on the patient's treatment team, culminate to form a strong care pathway for suicide prevention. My Mind hopes to support you all in your clinic's journey to strengthen your suicide prevention care pathways by providing tools such as education on the Plan, Do, Study, Act process, which you will receive in the upcoming Module 3 training as you start to prepare to complete a 2-week PDSA. So you will be inputting this information in the My Mind Partner portal once you have completed the PDSA, and we will be giving you some feedback on those and providing you with even more education on quality improvement in year 2. So next steps are to sign up for Module 3 if you haven't already, and become familiar with your practice's current suicide prevention processes to help you start to think about how to strengthen your suicide prevention care pathway and support safety for your patients, as well as prepare for the upcoming 2-week PDSA assignment that is due May 1st, 2026. We always include some references in case you want to check those out. And if you have any feedback, please feel free to reach out to the My Mind Coordinating Center. The address is here. Let us know how we're doing, how we can improve. Because we are part of a quality improvement CQI, we always want to improve too. So let us know how we can do any better. We're always open to that feedback. And I just want to say here that if you are struggling with emotional distress or feeling that you are needing some support, please call or text 988 yourself. So although we have this QR code here that you can share with patients, you're welcome to also call and text 988 yourself. We have to put on our oxygen mask before we try to help patients put on theirs. So make sure you're taking good care of yourself. Reach out to PO leadership or My Mind staff if you need more support, but also call or text 988 if you need it. and just want to always make sure that providers are thinking about their own mental health. Thank you for completing this training today, and for all you do to support your community and support patients with suicide prevention. You guys are all amazing. We are so privileged and happy to work with you all. And if you have any questions, don't hesitate to reach out to us. Let us know of anything that we can do to provide support, and I hope you have a great day.